called observation centers. And a treatment center of patients were called. The question is, are there high-risk, low-probability patients that could be perhaps use some of these guidelines on? Because I think when you come into the emergency room, the chest pain center experience is a meaningful teaching experience whereby we want to know what can they do to prevent. And these are, if you want to call asymptomatic patients, they can't have chest pain, but they will pull out. And I look at these is hard because in our own institution, we have 4,000 patients in the chest pain center. 2,000 of those patients are women. Now, right now, if you think there are about 2 chest pain centers in the United States, there's 5,000 hospitals. If you multiply, say, 5,000 hospital times about 2,000 activity, that's still high, you might get 5 to 10 million patients who are coming in and are being ruled out with the stress test and are going home thinking they're okay. The question is, are there high-risk, low-probability patients that you could use CERT-1? Chris Jordan has suggested monofluoxetase as a test because patients who are positive and ruled out have increased cardiac events in the next 6 months. Are there other tests?
One study of 200 patients, I think we are not ready to consider monofluoxetase. Consider CRB.
Whether or not these early systematic patients in terms of they didn't get ruled out, but they are a group of patients that could be used in order to affect studies on the calcium scores, URIs, just these players, CTA, and what. But the same strategy that we have to find can be implemented.
Depending on sort of assessment. structure and function of how it's analysis of that. Just don't let's let the government do a document out of this, everything's going to actually occur to it. So, and we just put on that everybody, we're going to conclude before lunch. So the meeting is done. The work is actually started for us over the case of the party, and now I'm going to carry this road for the next few weeks. This is the road that I've loved. I think this is so simple that it usually...
But I'm going to put that perspective of there and just substitute this act together for...
No, that is for 45. This is completely the conditions for age 45 to 54. What is saying in this group, 45 and above, 55 and above women, go after disease. In that way, go after risk factors. We can stop it. And it's actually stuff. Why is that?
But I think you could add up microalbumin in there because that is a predictor of myocardial infarction.
That's not what you should want to I think they will. So what's the fact?
Well, it's a testing.
It's even most in blood disease, when one of the is you have so many things in addition to that. Before I think the word most is too, we can laugh and cause them not to talk. And then we will do no recommendation that they'll have they come up with I think this is not
this practice for the younger age group develops. I talked about a book of this practice.
Yes.
People don't understand next slide. What's the talked about yesterday? Is that right?
Yeah, this is to read right. Here, the risk factor is part of the after the chest, was all after the risk factor. Yes, we have only included 4 or 5 states. Yeah, we don't have anything new. We're saying whatever risk factor they have, they're active. Now, the other point is that, well, you know what I'm showing the dollar bill here, so you can do it in $50. That's so don't close the eye and say, that would serve a negative significance. So, Somebody, I want to